healthcare system is broken, but it doesn't have to be. This is Revenue Cycle Optimized by Infinix Healthcare. We discuss the latest challenges in the revenue cycle space and provide actionable tips on how to overcome them at your organization.
Welcome everyone to another insightful episode. I'm Stuart Newsom, your host for today's session, and I'm thrilled to be joined by Julie Graham, the Senior Coding Manager here at Infinix, as well as an expert in healthcare compliance and audit processes. How you doing today, Julie?
I'm great, Stuart. Thank you very much.
So just wanted to give everyone an opportunity to know more about you. I know we've had you on previous episodes, several, so to speak, and you'll be on many more. But I just wanted to start by having you tell us a little bit more about your background, your experience, what you do here at Infinix.
Yeah, so I'm CPC and also certified in cardiology. I've been with Infinix almost 3 years now, and here at Infinix, I do provide coder education, physician education. That's basically the education part of it. And then I help with audits and I help with some AR stuff, claim denials and appeal letters as well.
Wow, that's a lot. It is very important as well. So having one of our experts is just kind of a testament as to how some of the expertise that we have on staff. And Julie just is one of the best. So glad to have you here
Thank
with us
you.
today.
Thank you.
So just kind of give an overview of what we're going to talk about today. Today's title is Mastering RAC Audits in Cardiology and Best Practices and Use Cases. So we're going to delve into the topic of RAC audits. That actually stands for Recovery Audit Contractor, if any of you didn't know, with a special emphasis on cardiology. So our objectives are really threefold here. So first of all, we want to try and understand the primary triggers for a RAC audit, especially concerning some high cost procedures. And I think in today's example, we may cover carotid ultrasounds. We're also going to identify some common documentation issues. It's always about documentation, and discuss strategies to improve compliance and reduce any of those audit risk. And then lastly, we're going to differentiate between some automated and complex RAC audits, so to speak. So, and provide some best practices for preparing and the appealing for those findings. Because sometimes the RAC audit may have some false positives that need to be questioned. So we'll dive into that as well. So when it comes to RAC audits, I just wanted to give a brief narrative regarding RAC audits. As we stated earlier, it stands for Recovery Audit Contractor. And people may be scratching their head and goes, well, where did these things come from? Well, they were first introduced as a permanent program by CMS in 2010, but this actually followed a successful demonstration is what they called it, or a project, if you will, a pilot is what I would like to call it. It started around 2005 and ended in 2008. So it was a little 3-year pilot on how successful they wanted to see these RAC audits become. So the initial program actually recovered $900 million in overpayments, but they also discovered about 38 million in underpayments. And both these figures really highlight the significant impact of improper payments on the Medicare Trust Fund. So if you break that down, I want you to consider that the 900 million in overpayments compared to 38 million in underpayments. I think people hear million and think, oh, wow, that's a lot of money. But the 900 million is actually a whole lot more, whereas the underpayments are only 4% of the overpayments. So as you can tell, there's a huge emphasis on this improper payments initiative that was initiated. So I'll get into that just in just a little second. But the program's origin actually goes further back than that. You can trace it all the way back to HIPAA. There was concerns that the Medicare Trust Fund just wasn't going to last, that it was also being misused. It was actually introduced in the Title II section of HIPAA on fraud, waste, and abuse. Kind of aging myself here, but I can remember back in 1999 or even 2000 in New York City doing a presentation speaking on HIPAA and dissecting this particular section because it was really causing a lot of anxiety, if you will, among providers, and rightly so. These initial efforts mainly involved government employees. So when they first came out with this program to go out and audit practices for improper payments, it was essentially Medicare partnering up with the FBI to be the law enforcement in charge of performing these audits. And it's basically they gave a bunch of accountants a badge and a gun and said, go get them. All right. But there was more involved in that, but they definitely were just, some people who were wanting to go in and do a proper audit and make sure it involved documentation, involved looking at past claims. So there's a whole lot of criteria there, but the point is they really weren't clinically minded. They didn't have a whole lot of clinical background, but these efforts were very fruitful for them. They actually had a 23-to-1 ratio in their yield. So what that means is for every dollar they spent on this program, they got $23 back. Now, I don't know about you, but anything that you gave a dollar, gave you $23 back, I'm doing that all day long, right? So it stood to reason that this was very successful and just encouraged them to pursue it more. So now there's this transition to private contractors, so to speak, and that's what these RAC audits are. And it really marked a significant shift in their way of thinking. So they're thinking, well, if we did this with government employees that had no incentives, what if we opened this up to contractors that we incentivized that got contingency fees based on the findings and what was recovered? So that's a whole new ballgame. So this change really led to increased scrutiny and more aggression, so to speak, as I like to call it, to approach audits and raising concerns about the burden of healthcare to providers. So part of this was also the CERT program. Now, I'm not talking about CERT with meaningful use or value-based care and using electronic health records. I'm talking about CERT that stands for the Comprehensive Error Rate Testing Program. And this is where Medicare audits their MACs, their Medicare administrative contractors, to find out what improper payments were made and where they were made, what areas they were made. So they work alongside those RACs to protect the Medicare Trust Fund. You know, that's the stance, to make sure that they recover those improper payments, and in some cases actually pay underpayments, as you can see, though, about 4% of what represents overpayments. So this has been a substantial financial challenge even since the mid-90s, but they are making headway. This is hard to believe that HIPAA, and this has been going on for almost 30 years now, but it's still a big issue. So that's why we thought it'd be good to bring on Julie. She has some experience in this, and we wanted to kind of ask her a few questions regarding RAC. And as she said, from her background, she actually works with physicians all the time when they are approached with a RAC audit. So Julie, first of all, just wanted to ask you if you could explain some of the primary triggers for RAC audits in cardiology practices, particularly when we want to look at concerning those high cost procedures like carotid ultrasounds.
Yeah, of course. So there are several issues that can trigger RAC audits, and those include things like upcoding, incorrect billing codes, lack of medical necessity documentation, and billing for services that aren't rendered. So it's crucial for healthcare organizations to be aware of these pitfalls and to avoid being flagged for an audit. Additionally, the topics of the RAC audits are that the RAC auditors are focusing on are approved by the Office of Inspector General, the OIG, and you can find those online. So you can, be prepared for that, research those. But a carotid ultrasound in and of itself, when we're talking about what is required, if this were in a RAC audit, what you would need to support, it's only covered when at least one of the covered indications listed in the LCD 35397 has been met, along with a covered diagnosis that is supported also in the billing and coding article A95992. Now, those two that I'm sharing, those are specific for Novitas, since we're in that area. So you would need to look up, depending on your MAC, to see what LCD or what billing and coding article, what they're looking for. And so you also need to ensure that none of the limitations that are outlined in the LCD and the billing and coding article have been met. You don't want to meet any of those limitations. And as always, documentation is key. Another thing that goes with this is E&M documentation. The E&M documentation should support the signs and the symptoms leading to the order and performance of a carotid ultrasound. For example, if the carotid ultrasound is being performed after a carotid endarterectomy, this should be documented in the patient's medical record, and there should be a narrative provided in the procedure note with the date of the surgery and the verbiage of carotid endarterectomy. And this is via the coding guidelines in the billing and coding article LCD A52992. So those are things that we look for or would look for if we had a carotid ultrasound audit. And those are some of the primary triggers for a RAC audit.
Nice, nice. And you mentioned E&M. I know E&M is always top of the list
Yes.
when it comes to those CERT reports that I mentioned earlier. And it's kind of a low-hanging fruit for to catch documentation errors. And so kind of segues into the next question is, what are the most common documentation issues that lead to findings of overpayments or denials during the RAC audits? So kind of a follow-up to that as well, kind of a twofold question. How can cardiology practice in particular improve their documentation to avoid
Answer.
some
Oh,
of
I'm
these
sorry.
pitfalls?
I'm
No,
sorry.
that's good. Go ahead.
No, to answer your first question, incorrectly coded claims. So approximately 35% of denials occur due to claims with incorrect codes. So ensuring accurate coding is crucial to prevent overpayments. You don't want to be billing for something that wasn't truly done or that doesn't really meet the definition of that CPT code. Another one is insufficient or no documentation, which is kind of what we were
Mhm.
just talking about. There are about 8% of denials result from insufficient or missing documentation or poor documentation, like where medical necessity hasn't been established. So properly documenting medical necessity, procedures, and services is also essential to avoiding those overpayment recoupments. Accurate coding of diagnoses and the procedures, again, is crucial for ensuring that your claims are paid correctly. You want to make sure that the diagnosis codes are relevant and documented in the record and that you choose the correct ICD-10 code. And then again, you want to make sure that when you're choosing your CPT codes, you're well aware of the guidelines for those, what codes are bundled,
Mhm.
what may be billed separately, because that is a big one. Timely and accurate documentation. This may not seem like something that would matter, but it really does. You don't want, and this is probably more geared towards the physician side since they're responsible for this aspect, but they don't want to wait, especially with procedures. Maybe with your more simplistic procedures, but overall, they don't want to wait on getting those procedures, getting that documentation prepared and completed. You don't want to wait 3 or 4 days. You tend to forget things sometimes.
Oh, yeah.
So you really want to pay attention to that timely and accurate documentation, accurate documentation that
Right.
supports medical necessity. So, and I kind of just said what I was documentation that supports medical necessity that's congruent with the coding guidelines and CMS guidelines. And, sometimes CMS guidelines are different than CPT guidelines. So you got to know where to look. You've got to know your payers, know what they want, what they don't want. And that can be a challenge at times because certain payers want different things and they don't always post their guidelines. So sometimes it's trial and error with them, with your commercial payers. But definitely, you always want your documentation that supports that medical necessity. And then, like I've kind of already touched on this, but one of the things that you can do to prevent these type of denials or to prevent yourself or to be prepared if you are the subject of a RAC audit is to discuss the carotid ultrasound documentation requirements that is set forth by your MAC with your physicians and with coders, for like a coding manager or a coding team lead to ensure that they're aware of these guidelines and what the documentation requires and what they're looking for. So their coders are looking for it and making sure that it's there. And then so the physicians also know and they're aware of what clinical scenarios support medical necessity for ordering these services.
Gotcha, gotcha. And you mentioned going back to the timeliness of documentation and the physician's responsibility. I can tell you that one of the biggest gotchas that some of these RAC auditors will look for is the documentation signed. And many times, if the record's not signed, then it didn't count. I mean,
Yeah.
so that's something as simple as signing the medical record could be the difference between having to pay back an overpayment and or retaining revenue. So yeah, those little things can add up.
And orders. Orders is
Right.
another big one.
And
They
orders,
do want to see
exactly.
those orders. Yeah.
Exactly. The orders matter as well, and where it was each order medically necessary as well.
Yeah.
that plays into it.
And if
Um,
you, sorry, my apologies. If you
you're good.
also, if you provide your coders with the tools that they need so where they understand what they're looking for, they can also do that, reinforcement of education with providers as well, which is a lot of what I do, reinforcing that education with providers, ensuring that they know what's going on, what they need to document, what meets medical necessity within their documentation.
Sure, sure. So can you differentiate between automated and complex RAC audits? Like how should a practice prepare differently for each of these types?
Yeah, so that's a really good question. So the automated review relies on an analysis of claims data to make a determination. Automated reviews are generally based on clear policies outlined in the law, regulations, or guidance, whereas a complex review requires a more in-depth analysis and almost always involves a request for medical records from the contractor. These may involve questions of medical necessity and the proper documentation or judgment is required. So, if the audit of your records determines you received an overpayment, you will receive an overpayment demand letter from the RAC. After receiving a demand letter, you are required to call the RAC within 15 days to discuss how you plan to proceed. In response to an overpayment demand letter, you essentially have three options. You pay it in full, you request an extended repayment schedule, or you file an appeal. In the cases where you're the target of a RAC audit, you may be able to get information about the type of review that was conducted based on the communication that you received from the RAC. In cases where your first communication with the RAC is through a demand letter, quote unquote, you are often the subject of an automated review because the contractor did not need the additional information from you to make the determination that an overpayment has occurred. So if you receive a request for information from the RAC for records or other forms of documentation, you are more likely the subject of a complex review. And this will require determinations of medical necessity and proper documentation before the RAC can determine if an overpayment has been made. So individuals or practices that receive requests for records have 45 days to comply. And then there's 5 levels of appeals. And I know that we exhaust our level 1 and level 2. The level 3 through 5 are much more in depth. So the level 1 is your first level appeal, and you have 120 days to file the first appeal. And you should get a determination from that within 60 days. The second level appeal is a reconsideration. If you aren't satisfied with the result of your first appeal, you have 180 days to submit an appeal to a qualified independent contractor or QIC who should issue a decision within 60 days. And the level 3s, that would be if you're not satisfied with your second level appeal, you would have to go to before an administrative law judge. And then, the process keeps going. Then you'd have a decision within 90 days. A level 4 is if you're not satisfied with that administrative law judge's decision. So then you take it to the HHS Department of Appeals Board. Level 5 is if you're not pleased with that, the HHS Department of Appeals Board, then you submit to the federal district court. And that requires an appeal minimum of $1,130 to take it to a federal district court. There's a lot
Oh,
involved.
there's a lot involved, and it sounds like I hear fees, I hear processes, I hear, determinations of what levels you need to be there. So it can be very complex. But again, having a plan in place, really matters when it comes
It
to.
does.
So with that, I know one of those is maybe appealing some of these adverse findings. So
Yes.
what are the best practices to appeal when it comes to a RAC audit?
Well, this is an administrative burden, but one that must be tackled.
Right.
So it all starts again with sufficient documentation that establishes the medical necessity for the services rendered. So if you encounter an audit, you need to follow the appropriate appeals process to address any of those denials. Your response to that RAC audit letter is critical. So if you receive this letter, don't delay. You have 45 calendar days to either submit a response or file an extension. If you don't respond, though, if you just wave it off or, think, oh, this is no big deal, then the RAC could decide that you were overpaid and it'll be immediate recoupment. You wouldn't get to state your case or send anything that supports that you have met, the coding guidelines, you've met medical necessity, and your documentation supports everything. So you can't ignore these requests. If you lose the appeal, we kind of talked about those levels previously, just a few minutes ago, the different levels. But losing the appeal, it does provide an opportunity for any clinic, any provider to improve. It accentuates an opportunity for coders to receive education at a granular level. And that could be things like ensuring that your coders know the most appropriate CPT code to select, based on those AMA CPT definitions of those codes, and make sure that those codes correlate with the documentation, make sure it's supported in that documentation. It's also crucial that your coders understand what NCDs and LCDs are, how to find these, how to make sure they're looking at the correct one for their MAC. That's very important. Some MACs have different rules, different things that they seek and that they want. So being able to navigate that and knowing where to find those resources is going to be really vital. And then, making sure that your coders know how to verify that the documentation includes the pertinent parameters that are outlined in the NCD or the LCD that will support medical necessity. Those are big things. And then physician education, that's another way, making sure that physicians understand that these covered indications and the limitations that are listed within the NCD or the LCD, like for, pacemakers, for carotid stents. There's so many things that the doctors really have to be aware of, or that they need to be made aware of. And that's where we come in as coders to help facilitate that. And then also discussing with them documentation that requirements that establishes medical necessity. These type of things where will help, save you from having to appeal. But if you have to appeal, these are steps you can take to boost up and, make it better so that next time you don't have these same pitfalls.
Sure, sure. So even if you feel like, oh, I don't feel like appealing, I'm not going to win, or we're busted, there's no need to appeal. Sometimes going through that
Yeah.
appeals process serves as a fire drill, if you
Yeah.
will, where everyone kind of, gets things in order for next time, to prepare for next time. But it also, to me, it always, it's just a stake in the ground. Even though you
Yeah.
lose that appeal, it's still on record that this was appealed. And the more appeals you have for this, they may take another look, for future claim submissions. So appeals plays a bigger role than just appealing a claim to get reimbursed for that specific episodic incident, right?
That's such
Um,
a great point.
yep,
Yes.
yep.
Yeah.
So with that, I mean, you mentioned audits, you've mentioned, as we talked about the fire drill that you discussed as well. How important are those internal audits in preparing for RAC audits? What key areas should people try and focus on to ensure compliance and readiness?
Yeah, so the internal audits would be another great tool to wield to ensure that you don't have to appeal things. You don't have to appeal and support your case. But, it's important to conduct these regular internal audits to identify and correct documentation issues before it becomes a problem, before a RAC is requested. And then when the RAC is requested, if a RAC were to be requested, then you would know that your documentation is tip top and it supports medical necessity. So these allow for those things to be eliminated before they become a problem for the RAC audit. And then the regular internal audits help providers identify and correct potential issues. And this can reduce the risk of overpayments and underpayments, because doing both will allow you to identify, oh, we lost out on some money here because we didn't quite understand that these codes, you can actually bill additional codes. You can bill the catheter placements, where some codes you cannot bill catheter placements. But so you can identify underpayments, you can identify overpayments, which will protect you and help you maintain compliance with Medicare regulations. And you just want to ensure that the medical records accurately reflect the services provided. You want to make sure that medical necessity has been established, of course, through documentation. You want to make sure that there's accurate coding of the diagnosis and procedure codes.
Awesome. Awesome. Well, these are all points well taken. I know this is the tip of the iceberg. There's so much more.
There
If
is.
anyone out there has experienced RAC audits in the past, you probably have some lessons learned as well. Sometimes the good old school of hard knocks can be the most important educator, but I think these tips are very valuable. So thank you, Julie, for coming on today. We're now just going to open up the floor for any questions from our audience. We do have one question here, and it says, the question is simply, how can we see if we are subject to additional revenue with underpayments? So I guess we've talked a lot about overpayments and that's the concern. And as I opened up, 4% underpayments represented 4% of what was overpayments, what was needed to be recouped. So I guess we need to alleviate on that a little bit. What is the process? Okay, so I've found an underpayment here. How do I recoup that if they're not going to voluntarily pay it to me? So I think both Julie and I can answer this. I'm basically, the first thing that comes to mind for me is you want to, analyze and review all your past claims. Like, how often did this happen? You want to run like a frequency report. What does the frequency look at? If you found an underpayment in one incident, did this occur for everything else? So that's obviously that review and analyze, where those underpayments may have occurred as well. Did it involve a CPT code? Did it involve a certain diagnosis code? You can get as granular as, okay, let's look up every incident of a CPT or every incidence of a diagnosis. Was it a certain payer? I know but some of the other private payers are also doing these kind of audits. So that would be the first step to me. I don't know, Julie, if you want to add any insight as well on beyond the first step I just mentioned.
No, I think that's absolutely perfect.
Then we also have like internal audits you may want to perform. But another thing that you want to look at is your fee schedule. I mean, it could be as simple that your fee schedule is not up to date and maybe you're undercharging. Okay. So just a good evaluation of your fee schedule. I've seen it happen more times than you would believe. Some people are like, oh, of course we update our fee schedules. But, just make sure that whether you're going through negotiation processes or whenever that the final rule for the fee schedule comes out every year, it's going to be coming out pretty soon here, I guess, a couple of months. Go right there, see what the RVU values have changed, see how those fees have changed, particularly for your CPT codes, because that could be an easy fix.
Yeah.
And you can go back and retrospectively say, hey, our fee schedule was wrong. And you could go through the appeals process. So that's just some things that come to mind when I look at that question. All right. Well, I don't see any other questions coming across. So Julie, once again, you were awesome as usual. Thank you so much for coming on board and
You're very
with
welcome.
us today. And everyone else, we appreciate, as always, you joining us. Please feel free to reach out to us at any time if you want to see a demo or you want to talk about some of our solutions, or if you just want to talk about some of the things that are bugging you in the RCM. I'm always open to talk about that. I love talking about RCM. So till next time, y'all have a safe and great week. Thank you.
Thank you.
Thanks for joining us. Subscribe to get notified when our next episode is online. For more information for how we can help you increase reimbursements at your company, check out our website at infinix.com. That's INFINX.com.